Good morning, everyone. My name is Bill Smith. I am a senior fellow in life sciences at the Pioneer Institute, and I'm also director of the Life Sciences Initiative at the Pioneer Institute. And I had a long career in government and in industry. About a decade ago, I joined academia and affiliated with Pioneer, and our aspiration is to build a first-rate life sciences policy program. Let me do a quick advertisement for our Life Sciences Initiative. As people on this call, I am sure know that the greater Boston, Cambridge area is probably the most important cluster of life sciences expertise in the world. California may criticize that position, but their life sciences sector tends to be spread out, not located in a single place. So this ecosystem that's been created here is extremely valuable. It's first-rate universities, it is academic medical centers, it is venture capital firms with an expertise in life sciences, it is small biotech, it is large pharma research labs. It is a very important ecosystem for a variety of reasons: national security reasons, economic development reasons in the region, and most importantly, for patient reasons, because they're working on some really neat medicines. So at Pioneer, we felt as if this ecosystem was important enough that we should be thinking about policies around it that would protect it, provide greater patient access, and look at some of the policy challenges around life sciences, but recognize the importance of this ecosystem for a variety of reasons and give it some policy support. So that's my advertisement on the Life Sciences Initiative. Stay tuned. We're going to have a more robust program this year. Look for our research products and invitations to events like this. And hopefully you'll see more and better programming. I'm going to introduce first our two other excellent panelists. Terry Wilcox is co-founder and executive director of Patients Rising and Patients Rising Now. She's one of the most articulate and prolific advocates for patient access to therapies and diagnostics. And I know for a fact that thousands of patients and caregivers look to her for advice on challenges they may be having. So Terry's going to talk about the patient perspective on this 340B program we're going to discuss today. And then Robert Popovian, who I will say is a friend. We served together in industry. He was a vice president at Pfizer when I was at Pfizer, and that was many moons ago, but we've remained friends. He's the founder of a strategic consulting firm called Conquest Advisors. He wears many hats. He's the chief science policy officer at the Global Healthy Living Foundation and vice president of economics and policy for Equidium Health. And he's also, last but not least, a senior policy fellow in healthcare at the Progressive Policy Institute. And he serves on the board of counselors for the School of Pharmacy at USC. He is a very thoughtful analyst of policies that impact the economics of the pharmaceutical industry, and he will have some thoughtful comments, I'm sure. So let me just quickly go through what the agenda is today. We hope to get you out of here within an hour. I'm going to open things, and I'm going to give an overview of the history of the 340B program and give hints about some of the challenges that have arisen in recent years. I think Robert will then go and dive a little deeper on some of the policy and economic problems that have arisen with the program. And Terry will talk about some of the challenges that this program creates for patients. One would think that a drug discount program would be an unadulterated blessing for patients, but there are some challenges that this program creates for patients, and Terry knows them better than me. We're hoping to leave 30 minutes for Q&A. So please submit your questions on the Q&A chat function, not on the chat function. I'm not proficient enough with my computer to check both the chat function and the Q&A, and I will go to the Q&A and we'll try to get to as many questions as we can. So let me open up and just give a quick overview of the 340B program. And I was astonished by some features of this program when I started reading about it. In the 70s and 80s, when the country had many more uninsured citizens, there were certain hospitals and clinics that were located in underserved areas that had financial challenges based on the fact that they were giving away free care. Anybody that came into their emergency room off the street was going to be treated like any other patient. And pharmaceutical companies, many of them recognized this, and they started giving concessionary discounts to those types of clinics and hospitals. So it was a volunteer. It was a volunteer thing that developed. In 1992, for complicated reasons, the federal government decided we're going to mandate this program and mandate these discounts for certain hospitals and clinics. And to be eligible for the program, you had to treat a certain percentage of Medicaid patients. And the federal government felt like the number of Medicaid patients you were treating is a proxy for whether you're serving underserved communities. And the program worked quite well for a number of years. As late as 2004, there were only about 500 hospitals in the program, and it was they were limited to largely to underserved areas. But then a few things happened. The program really started to see explosive growth. When the Affordable Care Act kicked in, for example, the number of people enrolled in the Medicaid program expanded exponentially. And because there were so many more people in the Medicaid program, more hospitals were treating more Medicaid patients, making them eligible for the 340B program. So what is the 340B program and how does it work and why do hospitals want to be involved with it? One, for the right reasons, hospitals want to be involved with it because they may treat underserved patients, they may treat uninsured patients or low-income patients, and that program helps their finances when we're treating those patients. But there are other reasons why a hospital might want to be part of this program, because they can arbitrage the discounts that they receive under the program. And what do I mean by that? So to use a simple example, you're a hospital that can buy an oncology product for $25,000 under the 340B program. But that oncology program has a WAC price or a sticker price of $100,000. So that structure provides a strong incentive for hospitals to bring in patients, particularly insured patients, either in Medicare or on commercial plans, bring them into the hospital, give them the $25,000 oncology drug, and then bill the commercial insurer or Medicare $100,000, which creates, of course, revenue stream of $75,000. And these discounts are being arbitraged in this way because there's no requirement under the law that the discount goes to the patient, that certain low-income patients be treated. The law was very bare bones and, in my view, poorly written, and it allows for this kind of arbitraging. And because of this, the program has absolutely exploded. Within a year or two, the 340B discount program will be the largest federal drug program, larger than either the Medicaid drug program, which has 80 million enrollees, and larger than the Medicare Part D program, which has senior citizens that tend to use a lot of drugs. So this program is huge. And there are one would guess that the sales in this program are close to $40 billion by now. But there was one study by an economist who concluded that in 2019, the additional revenue secured because of the arbitraging of these discounts by hospitals was $40 billion. And there are now 2,500 hospitals participating in this program. And so my big concern is that the program has gotten away a little bit from its original goal, which was to treat low income and uninsured patients and to provide hospitals with the ability to dispense a lot of charity care. So we released a paper today, which I hope you will look at on the Pioneer Institute website, in which we concluded that, based on the national data in particular, it looks like charity care has been declining significantly as the 340B program has been growing. And one would have think the opposite would have happened because there's so much revenue being generated for hospitals. So the national data, one study in the national data concluded that there's actually an inverse relationship between the amount of charity care, the ability of low income and uninsured people to get medicines and healthcare. There's an inverse relationship with that with the growth in the 340B program, which is very troubling. So we wanted to look at some hospitals in Massachusetts and see what was happening with them as far as charity care. And we picked 5 hospitals, not at random, but based on a regional basis. We wanted to look at a large hospital in Eastern, Central, Western Mass, one in the Berkshires and one in Cape Cod. And what we found in these 5 hospitals is that there was a straight line down in their provision of charity care from 2013, 2014 to now. And again, I don't want to cast too broad a brush on hospitals and clinics as far as their dispensation of charity care, because we did find a couple hospitals in Massachusetts, for example, the Boston Medical Center, as well as the Cambridge Health Alliance, which is Cambridge Hospital and Everett Hospital. Their dispensation of charity care was very, very generous. And it was not a straight line down from 2013. It went up some years and down some years. So I don't want to, again, cast with too broad a brush. I think there are institutions out there doing yeoman's work as far as dispensing charity care. But I think there are others that have taken advantage of the program that have not raised their charity care expenditures when one would have thought that they'd have the revenue to do that. And there are other problems with this program that I hope Robert will go into. I think, there's an incentive on the part of hospitals, for example, to open up satellite offices in wealthy areas so they can arbitrage these discounts more effectively. And we've seen oncology practices or infusion clinics and other types of clinics that tend to dispense more expensive drugs that are being bought up by hospital systems. And there's also an incentive that one should recognize for this program to dispense more expensive drugs, because the spread on a $150,000 drug is larger than the spread on a $10,000 drug. So the program has developed all sorts of unintended consequences. And I think really Congress needs to take a look at it. We make some recommendations in our paper. But I'm going to leave it to Robert and turn it over to him to go into some more detail about the economic and policy challenges of this program.
Thank you, Bill. Thank you so much. And I'm so happy to be on this webinar because it's, again, discussing incentives in the marketplace. And as an economist, I can tell you incentives matter. So a couple of things I want to actually update, and Bill did a great overview of the 340B program. This morning, actually, we got data from Drug Channels through Adam Fine's shop that the number has actually grown even further. It's about, the 340B program is about a $50 billion incentives that are pushed back into the marketplace through the pharma companies. And it has surpassed Medicaid, actually. So it's the second largest sort of like dispensation or pushback to the market after Medicare Part D. So it has grown. And it keeps growing, and incentives matter when you talk about this. And the other thing that I want to mention, it's just not about the hospitals and the growth in the hospital and the 340B program, but also the pharmacies. There's been an exponential growth of pharmacies over time. And, all of these programs, as Bill mentioned, start with very good intentions, but end up being out of control. And the reason being is that the incentives, again, let's go back to the incentives which matter, which is very similar to rebate contracting on the retail space or the pharmacy space, not only retail space, but the pharmaceutical space with regards to pharmacy benefit management companies and insurers. In that space, you see formularies now being developed by these pharmacy benefit management companies that incentivize use of more expensive medicines instead of generics or biosimilars. And, just to give you an example, one of the largest PBMs released their 2022 formulary, and in it, in 10 occasions, they restricted the generic formulation in favor of a brand name drug. And that's what's happening in the 340B program. It's just like Bill says, it's an arbitrage because incentives do matter. And, and it's not just the economists that are talking about it. General Accounting Office put out a report that showed that in 340B program, the incentives push more prescription of more expensive medicines for patients. And this ends up hurting a lot of people because what happens is that it hurts the community oncologists who don't have access to this type of pricing. And what happens is that these hospitals, again, come in, they buy these practices and they create access issues that I'm sure Terry's going to be talking about. So incentives matter, and 340B program has created bad incentives in the marketplace, similar to the rebate contracting that we've seen in the pharmacy benefit management program. And again, it's the same issue of higher list prices, higher rebated prices, higher discounts based on 340B, drive utilization of these medicines first. And what has happened, everybody agrees, including GAO, that this continuously is taking place. Now, the question becomes, what do you do about it? Because the reality is some of this discounting and providing of money back to through the 340B program is used for charity care, as Bill mentioned. But so, in my opinion, the easiest fix would be to have the discount for 340B follow the patient instead of the institution, because we know these institutions also, provide care to other type of patients. So why doesn't the discount follow the patient instead of the institution? That would be a simpler way of doing it. The second solution is really to do a post or retrospective sort of rebate program that some have proposed instead of a prospective discount upfront to these institutions. So that will also provide us an ability of not having double dipping with regards to Medicaid discounts versus 340B discounts, and it will help with reconciliation. So, for example, if the product is used for a patient that is qualified for 340B, then that institution, that pharmacy gets reimbursed back by a pharma company with a rebate to the system. So one is follow the patient, the discount, instead of the institution. Two is to do post sort of administration reconciliation through a rebate program. And the third thing is to make sure that the money flows back to the patient directly. None of this money and discounts and everything else is going back directly to the patient who's consuming these medicines. And it's the same problem with the rebate program. So those are the three solutions, which are more often than unlikely to happen because it's going to require a lot of changes. So what we're seeing in the state level, and this is very important, is that states are passing laws, transparency laws, to see where the flow of money is going. And this is no different than states passing laws to see where the PBM discount, all of the PBM rebate contracting and the fees are going to. So perhaps as an interim step into really fixing the program, which is to me, the discount following the patient rather than the institution, we should promote legislation on the state level, which is already happening, but more importantly on the federal level, to seek transparency and audit rights to see where is this money going? Is it truly going to charity care? Is it truly going to the bottom line of enriching the hospitals and the pharmacies that are qualified for 340B? And then we will be able to provide better answers and better policy solutions. But so far, only a handful of states have taken on this task, and it will be very useful for us to have a transparent model where we see all of the flow of the money similar to rebate contracting of where the dollar amounts are going. When we find that out, then we can make better policy solutions. But at this point, the system is rigged. The patients are not benefiting directly, as Bill mentioned. The charity care has been all over the place and mostly going down. And the most important thing is there's no reason why this discount is following the institution rather than the patient, when we know these institutions also treat other patients rather than just Medicaid eligible ones. And the program is growing and has surpassed Medicaid. So with that, I'm going to turn it over to Terry to really talk about the access issues that patients are seeing with regards to this administration of the 340B program.
Thank you, Robert. It's great to be here today to kind of shine a patient light on the 340B program, which, as many of you may know, is often difficult to do. It's sometimes hard to show that line directly, explain to patients and other patient advocates the direct line of how the 340B program is affecting them. And as has already been stated, the 340B drug discount program shows us how a well-intended program can be abused and ultimately hurt the people that it was intended to serve. Several years ago, when Patients Rising was in its infancy, we first launched, I was reading a story out of a Miami paper about an uninsured woman that received hundreds of thousands of dollars in hospital bills for her cancer treatment, from a local hospital there in Miami. And one of the line items on this bill was a $27,000 charge for an oncology supportive care medication that had an average wholesale price of $5,700 at the time. Now, not only did they charge her $27,000 for it the first time, they charged her $37,000 for it the second time. And I always said, well, what's $10,000 among friends? I mean, it was a crazy bill. Now, the article in the local paper that I read called it drug company gouging, and even a hospital doctor was quoted as saying this. And, you know, even being in our infancy at the time, I knew something was wrong with that picture. It was an outrageous bill on its face. And just looking up the average wholesale price of the medication, which was mentioned in the article, I knew what it was. I knew what the list price was. I knew what the average wholesale price was. And then come to find out, we learned that the hospital she was in was a 340B hospital. And that was kind of the beginning of my realization of how off the rails this program had become. Now, that story was 6 years ago, and today it's even worse. Another organization that we follow closely on this issue, because they've done some fantastic work in lobbying and other efforts in the 340B space, is the Community Oncology Alliance. We've read a lot of their information on 340B, and they have provided some fantastic examples on how the program has turned away patients that are, they're turning them away, and they're, and these doctors are, these hospitals are literally being paid to help, these patients by being able to get these chemotherapy drugs for a small fraction of the actual price. So there was a singer in her early 50s who had a mass in her breast. She was uninsured. She went to get a mammogram at a mobile mammogram unit. They noticed an abnormality and sent her for a biopsy, which confirmed she had a HER2 positive breast cancer. Now, she went to the local 340B hospital for treatment. She was turned away. She was placed on a waiting list because the 340B hospitals have put a cap in many instances on how many uninsured patients they'll see each month. So in her case, the cancer was left growing unchecked. Another example of a patient affected by a 340B hospital policy was an elderly man. He had multiple disabilities. He was diagnosed with a blood clot in his lung. He was prescribed an oral anticoagulant in combination with a series of other injections, et cetera. In effect, he needed a few small shots along with a simple blood test to be done over a short period of time, a weekend, I think, to make sure the medicine was working. The local 340B hospital wouldn't take him. The patient was left crying. Another patient, stage 3 breast cancer. She had no insurance and no money. She desperately needed chemotherapy to shrink her tumor before surgery. Her doctor tried to get her into a 340B hospital, explaining she needed daily shots and blood work, and it would be very taxing for her to drive daily an hour and a half each way to the alternate hospital. As always, this hospital in this instance refused. So the patient had to get in her car and drive 3 hours round trip every day for a 5-minute shot to boost her white blood count. And these stories, there's many of them. They go on. And what it shows is, these hospitals are in these communities to help patients like these. And in many instances, in the Community Oncology Alliance, and one of their stories, obviously, since they are the Community Oncology Alliance, is they're showing how many community doctors are picking up the slack. And they're not getting 340B discounts, which, and they, in many instances, that's why I liked Robert's point there that if the discount could follow the patient, as complicated as that would be fantastic. One of the doctors that has explained it this way: despite these hospitals' tax exempt status, and despite the fact that there is physician time and clinic space available, many 340B hospitals have decided internally on a specific budget limit for treating indigent patients, which translates to a certain quota of patients for the month. And once they exceed that quota, they start turning patients away at the door. So instead of using their resources on patients who actually need 340B drug discounts, the hospital can enjoy all the profits coming from 340B by treating more affluent patients or gouging patients, like the example I gave right at the top of my speech. There are multiple stories, like I said, of patients who should be supported by these hospitals that are being turned away. The 340B program, as Bill stated at the beginning, is a much needed program, and that if used as it was intended would be a fantastic resource for the patients who need it most. We believe that Congress needs to act on reining in this program by putting some guardrails and accountability in place. And the system is rigged and it needs more transparency. And the bills are positive that are popping up in the states on that front. I invite now, thank you very much for taking a listen. I look forward to engaging in conversation further. I invite Bill and Robert to join us back here.
Thank you, Terry. So just to clarify for everybody, there is no obligation, legal obligation on the part of hospitals to pass on the discounts to patients when they come in. Is that correct, Terry?
Yes, that is correct. There is no legal obligation to that.
Okay, well, we've got a few questions in the chat, and I'll start answering the first one. And the question is, what is the definition of charity care? This questioner points out that 90% of the patients in Massachusetts have some form of insurance. So one would expect charity care to be declining anyway. And that turned out to be true. So first of all, there is no real definition, tight definition of charity care. So for example, if a patient comes into a hospital and they have a co-insurance requirement for their medication and they don't pay that to the hospital, they just don't pay it. And they're a middle-class patient, they're not a very low-income patient, and the hospital writes off that expense because they never got the co-insurance. Is that charity care? Some people say yes, some people say no. Another problematic issue is Medicaid. Medicaid tends to underpay hospitals for all sorts of services. So if the price of an MRI at a particular hospital is $3,000 and Medicaid only pays $1,000 for one particular patient, can the hospital write off $2,000 as charity care is the question. My impression is some do, some don't. So one of the recommendations we make in our report is that charity care have a much tighter statutory definition, so we know exactly what it is. And I will point out, it is true that Massachusetts has a very high rate of insured patients. They've been working on this since Governor Romney was around. The Affordable Care Act came along, and there was a policy goal in Massachusetts to cover a lot of patients, and they did. So the question is, why was the 340B program exploding at a time when the Massachusetts rate of insured patients was rising significantly? One would have expected that the 340B program would be less needed under this in the Massachusetts setting because of the high rates of insurance. But that wasn't what happened, which is problematic from a policy perspective, because the entire goal of creating the 340B program was to serve these uninsured, low-income, and underserved populations. So again, one of our definitions was to tighten the definition of charity care and make things much more transparent as far as revenues coming in for 340B, and then what percentage of those revenues are being spent on charity care, and what are we talking about when we talk about charity care. The next question I'm going to turn over to Robert, because we got a question about what research would be valuable to educate policymakers about some of the unintended consequences of 340B. So if, Robert, you could commission a study, how would you structure that study? What questions would you take up? And what research areas need to be explored so that policymakers can reach some conclusions about what's going on?
I think a couple of things. Number one, I think I would look from a research perspective is that where is the flow of money going? Right? That's the most important thing. Is it going truly to charity care, or is it going to bottom line and enriching the hospitals and pharmacies that participate in the 340B program? So this is where transparency comes in. And this is why these legislations in the state level are so important for them to pass, because we want to know where the money is flowing. Now, if truly it is going to charity care, then that's great. Then that was the intended consequence. But if it's not, then we need to know. So that's the type of a study that I would design to be able to follow the money and be able to see where the flow of money is going and whether or not it is actually helping patients. The second thing I would do is to see if there's any kind of problems with regards to hospital. One thing Terry mentioned, because of this arbitrary percentage level that if the hospital or pharmacy sort of takes care of this X number of percent, which I think is 12% or something, that automatically they qualify for the 340B program, to see if, in fact, that's where it stops. That is the ceiling. That means that they don't take any more patients above and beyond that, because it's really going to provide the issue of whether or not there's access for these patients. So that's the second part that I would say we need to study to see if, in fact, these hospitals, do they stop, or pharmacies, do they stop at 12% and they don't take any more Medicaid patients above and beyond that? Or do they go beyond that level and make sure that it's being serviced? So that's the second thing I would look at. And finally, I would say to see where, how often are these hospital formularies and utilizations really driving more expensive, more utilization of medicines compared to commercial side. I know there was a study, actually, again, from drug channels a few years ago that showed over 50% of the purchases in the hospital systems was coming through the 340B program. On the face of it, just doesn't make sense, because we don't have 50% of our patient population seen by hospitals as being indigent. So that's the third thing, is to see how is it, what is the level of this type of thing that regarding the utilization, and is it driving higher price, higher cost utilized medicine? So those three things are the ones that I would start with and try to promote. But it starts with, again, Bill and Terry, it starts with transparency, because unless we have the data, the accurate data, there's no way we can make these policy shifts. And we need that information. That's why I commend the states that are trying to pass this legislation to see where the flow of money is.
Robert, let me go back to you with another question, because one thing that's happened in the 340B program that I'm not sure was intended by Congress is that a large number of for-profit entities, chain pharmacies, specialty pharmacies, PBMs, and others are extracting enormous profits from this. This program was intended to help nonprofit hospitals serving underserved populations. But suddenly there's been an explosion in the past decade or so, especially in the number of contract pharmacies and PBMs that have been involved. How are they making money, and how much money are they making under this program?
Quite a bit, because you've seen the exponential growth, right, in the last few years. So you know that, like any other business, you're not going to get into that business model unless you're making a lot of money. So the exponential growth just demonstrates to you that there's a lot of profitability that is being made through these. And it's very important to note, one thing you noted here is that pharmacies are no different than pharmacy benefit management companies, because specialty pharmacy is really being driven. This is where big margins come into play, right? It's the brand name drugs. Almost all of brand name drugs in the United States go through a specialty pharmacy. As 75 to 80% of specialty pharmacies are owned by these pharmacy benefit management companies. So just put two and two together, why you see this exponential growth of this, because that's where the margins are. So I would say that's one of the areas that we need to focus on. But because we have this arbitrary percentage level of Medicaid, these people qualify legally to be 340B providers, because they can demonstrate that they're serving Medicaid patients. But we all know with the Medicaid expansion, and you mentioned this, Bill, that we have a huge Medicaid population in the United States that helps these entities to qualify for these things. So that's why I think eventually what we need to do ultimately is having the discount follow the patient rather than the institution. And that way we will solve all of these ills. Now, the pushback I get when I say this is people make excuses about how difficult it will be to open up the law, to make changes. And, I will quote you, because you've told me this in the past. We're not trying to attach neurons here, guys. We're not trying to land people on Mars. This is a simple fix that we can do, but it becomes so difficult because so many people are making so much money. The other thing I have to say, which bothers me, is that you would think that insurers should be working on this problem, because they're overpaying for these medicines, right? But technically, if you think about it, insurers and pharmacy benefit management companies are truly the middlemen, right? So not only the profit for it, but even if they have expenses, they just pass it to the ultimate purchaser of or payer of healthcare in the United States, which is either the patient or the employer, because they're the only entities that really truly pay for healthcare in the United States. The government pays for healthcare, but they tax us as individuals. So at the end of the day, they're not even in the incentive. They're passing on the expenses as much as this is growing, back to the ultimate consumer or the payer of the healthcare system in the United States, which is the patient and the employer.
So Terry, let me turn back to you, and I want to ask about, besides your organization, what could policymakers do to educate patients about the availability of these discounts? You know, a patient walking into a 340B hospital should know they don't have to pay full price necessarily, particularly if they're low income. And they should be able to almost demand the 340B price, particularly if they're paying co-insurance or they're uninsured. But I'm not sure patients know to do that. Could we make them more aware?
Well, I think this falls into the transparency vein, but I think another thing, and this is a through line through a lot of stuff that we are working on now across the board. It's no different with 340B. There should be a requirement for them to disclose. We're a 340B hospital. You know, you can apply for, if you are uninsured or underinsured or whatever, you know, a listing of criteria that they set forth. To your point, there is no specific criteria bill that they're forced to use or for a certain amount, but there should be, there should be something that they're forced to disclose, that so patients can understand that they have options and they won't be stuck being turned away. You know, many of the patients that I gave examples of in when I was speaking, they had no idea. They were just being turned away because they knew there was another hospital down, you know, 2 hours away, or a community oncology clinic or a community clinic of some sort that would pick up the slack. And so I think that would be you know, one of the things that we would definitely support and get behind is just transparency in the program, not just transparency, you know, of the dollar amounts, but transparency to the patients themselves, who it's intended to serve.
Robert, let me turn back to you, and let's get away from drug costs a little bit, and let's just talk about healthcare costs and the 340B program. There's been some studies and some data to suggest that the expansion of satellite offices by hospitals into wealthier suburbs and the suburbs generally is going to make it many more people treated in hospital settings. Even if it's a satellite office, it's still a hospital setting. And isn't there can't you reach the conclusion that overall healthcare costs are going to go up based upon the difference between community-based healthcare that is not affiliated with a hospital and hospital satellite offices?
Should turn off my mute, but absolutely. I mean, providing care through the hospital system is far more expensive than providing care through the community. Whether it's the community oncologist or the rheumatologist who's practicing in the community versus having the patient either go to the hospital or be serviced by one of these clinics, as you said, or providers that has been purchased through the hospital system and now is billing through the hospital mechanism rather than the other entities. So yes, absolutely, it's going to drive up healthcare costs because we know at the end of the day, hospitals are the most expensive way to provide healthcare in the United States. They're far more expensive than providing care in a physician's office, whether it's an infusion drug. It's far more expensive than providing care in a patient's home through, you know, infusion, for example, to provide the care for the patient at their residence. So overall healthcare costs keep going up. We're going to see this happening over and over again. And what happens is that as one of the things that I would say also I forgot that we need to study is that how much does 340B hurt patient access and reduces patients' ability to get care in the community and instead has to go to the hospital system or drive or even go to a system that is being built under the hospital care. So again, these things are just going to keep driving prices higher. They're going to, because ultimately somebody's going to have to pay for it. And that somebody is going to be employers or the patients. And the patients are going to either pay for it truly opening up their wallets and paying for these things at much higher prices, or they're going to have to pay higher taxes because the government is overpaying for these things. You know?
Yeah, Terry, let me go back to you because there's some evidence to suggest that some of the newest entities to enroll in the 340B program since about 2004, 2005 are now located in wealthier areas where there are more insured patients. Now, this seems to me to be just completely counterintuitive to the spirit of this law, where you were hoping that 340B would help a hospital where an uninsured patient would wander into the emergency room because they had some ailment, and the hospital could afford to treat them for free because of the 340B program. But we have some data to suggest that the opposite is happening, that more and more of these 340B entities are locating in wealthier and areas that have high rates of insurance. Is it a logical reform that we require as part of the 340B eligibility process that you be located in an impoverished area?
Absolutely. I mean, Beverly Hills should not have, should not have a primary 340B hospital, nor should, I would argue the fair, where I am in Indiana, Virginia. I just think that there are that having, the popping up of these 340B hospitals in those areas is a bad sign for the program. It's a bad look for the program, quite frankly. I mean, it should be in areas where the most needed patients are. There should be a requirement for how those patients are served and tracked or looked at, which there is not now, which we have stated. And if a hospital in Beverly Hills is going to be, listed as a 340B hospital, then they should definitely be required to meet, some overflow from other counties in the area, or they must be doing something to earn that. I mean, how they're justifying making those hospitals 340B hospitals is, not transparent or even clear. So I think that there's definitely a lot of work that could be done there in disclosure.
Bill, this boils down to the arbitrary percentage that we have for this program, right? It's some percentage that's been set up by law, and it worked out well in the past. And for full disclosure, I did my residency in LA County USC Hospital, which in 1990s was providing exclusively Medicaid, but primarily free care to patients. Those were they were coming in, and it was desperately in need of revenue. But since then, we've had significant changes in law through ACA, where there shouldn't be anybody getting free care anymore in these hospitals, especially a state like California, which has expanded Medicaid significantly. So the question becomes, are we trying to provide a 340B program to subsidize lack of reimbursement through Medicaid? And should we go back and take a look at the Medicaid program, like you mentioned? Are they artificially paying low fees and driving these hospitals to behave as such in this environment? And that's another question that constantly comes up, and again, drives down to the incentive issue, as most economists will discuss.
So Robert, let me get into the weeds a little bit, but let's talk about the duplicate discount problem, because I've seen Inspector General reports and all sorts of government authorities who instruct the 340B program to HRSA, the agency that runs it. You've got to end this duplicate discount problem. This is a violation of federal law. The statute says duplicate discounts can be paid, and nothing ever seems to happen. It's the chronic violations of federal law keep happening, and nobody seems to be upset about it. It's just interesting to me, but it kind of explain at 30,000 feet what the duplicate discount problem is.
So, Bill, it's simple. It's basically a hospital that gets a discount for the drug for Medicaid because there are mandatory rebates, supplemental rebates, and fees and everything else that goes into the Medicaid discount program, and then gets additional discounts through the 340B because they qualify as a 340B entity. So it's called duplicate discounts. That's the term, that you're getting discounts from both entities, but you should pick one or the other. You shouldn't be eligible for both. Now, what I mentioned, one of the solutions that has been proposed is that if we go to a back-end reconciliation where a patient gets treated, they become eligible for 340B, and then the dollar amount is rebated back to the institution, This will create an environment that we get rid of this duplicate discount program. And in fact, what will happen is that at the end of the day, only patients who are eligible will get the 340B pricing, and we can solve some of these issues. I mean, you still have problems with regards to, increase in utilization of more expensive, more drugs and everything else, but at least it will take care of the duplicate discount program that exists.
Yeah. Thank you. We have a couple questions that have come in. Terry mentioned a story about a patient who was overcharged by tens of thousands. The patient and physician blamed it on a pharmaceutical company, but it was a 340B issue. Are there numbers and estimates about how many patients are overcharged because of 340B abuse? Have you seen any studies about that?
I haven't personally seen any studies specifically on that issue. It would be a good one to take a look at. I don't know if Adam Fine has done anything specifically on that, or anyone else has. We sort of track these outrageous hospital bills stories as we've looked at, patients' bills who've been gouged. And often one of the line items in the gouging is a drug, generally, oftentimes a chemotherapy drug or a very expensive drug of some sort. And it's very simple to check that. I find how uncurious the media is in checking that to be interesting at best, but no, we haven't. It would be interesting to have a study on that, because I'm sure it's quite significant.
Yeah, and I'll turn this next one over to Robert. I think I know the answer, but it's a very good question and an important question. We've been talking about it. How can researchers identify the amount of 340B discounts going to specific entities? And where do they go to get the data needed to calculate those figures? And if state and federal lawmakers want to require disclosure, how should their legislation specify the who and what of required disclosure?
I think let's answer the first question. Is similar to the disclosure laws that are being passed regarding pharmacy benefit management companies, the rebates and the fees and everything else. The flow of money is just that you have to report back exactly what happened to the money, how much money you got from the pharmaceutical industry, and how much of it, where did it go? Did it go towards charity care? And you have to disclose this in a way annually to an entity within the state. And that's what the state laws are being developed to do. It's very similar to the rebate issue and disclosure on the rebate problem. That's going to be the first step. But the second question is that how could we identify, are they going to the recipient entity? It starts with the data. We need to have the disclosure data. We know that states have passed. Let's step back, right? So we know one of the biggest fallacies in the marketplace was that 20 or 30% of premium dollars were going towards pharmaceutical spending. We've been able to show that that's absolutely false in the last 4 or 5 years through the state of California. State of California passed a bill in 2017 that required insurers and the pharmacy benefit managers disclose to the state how much of their premium dollars actually were used for pharmaceuticals. And what it's ended up being in the last 5 years, it shows it's about 12%. It's not 20, 25, 30% that everybody was claiming. So when we start getting this type of data, then we can start like changing the policy, and we can see the flow of money and whether or not it's going directly to the patient care or is it going to the profitability of the hospital system.
Yeah, and on this point, when we first started the research on the paper we did for Pioneer, I wanted to find out, the level of revenue that Massachusetts hospitals were getting, and it just wasn't simply available. Now, we had suspicions about the amount of revenue they might be getting because the program grew from $9 billion in sales, I think, in 2014 to $30 billion in sales, or $38 billion in sales recently. And moreover, as you pointed out, Robert, we saw for some of these hospitals, within 10 years ago, they only had 3 pharmacies dispensing 340B drugs, and now they have 200 pharmacies. Some of that data is in our report. And one can only conclude that the sales must be exploding if you need that many more pharmacies to dispense these drugs. So some kind of disclosure on revenue from 340B for these recipients, I think, would be very valuable for policymakers.
Bill, as an economist, when you set up the incentives as such, business is going to follow, right? I mean, this is not a mystery. There's a reason why we have formularies now with pharmacy benefit management companies that require a patient to fail on a brand name drug before they get the generic. Why is that? Because there's high rebated, high priced medicines. And we should not be surprised that the same thing's happening with the 340B program with regards to the growth, because there's so much margin to be made that it is very lucrative for these entities to invest in these pharmacies. And because we have this arbitrary percentage level, they technically qualify. So we've sort of set up the system for it to become what it is.
We're getting some interest in Terry's price gouging stories from patients. And so we got a question of, is there an open source database of some of these stories? Does Patient Rising have a website where you can go and see them? I know there have been oncology groups who have written about some of these stories on an anecdotal basis, but tell us more if people want to learn about what's happening to some of these patients in the 340B program.
Well, oftentimes, generally, we'll either talk about them on the podcast or we'll write a blog about them. I think, now that you mentioned it's probably would be an interesting idea for us to partner with some of these other organizations like Community Oncology Clinic and some others to kind of talk about, to sort of put into perspective in one location. It's a great idea. Unfortunately, we have many of them. We've written about many of them, but I don't have like a one location resource. I know Community Oncology Alliance has their 340B. They did like a report, and that's where I pulled several of their specific stories from. And they have many more. Oftentimes the problem, which is the case with many things, is the patients and oftentimes the doctors that work at these hospitals are afraid to be on record because they're paid by the entities getting 340B discounts, not the patients per se, but especially the doctors who they're the ones who can draw the lines of the 340B connection better than the patient who's walked in. Those are patient stories, but who drew the lines that it was a 340B hospital issue were the doctors that Community Oncologist Alliance talked to within their network. So good idea. My brain is churning on what we could maybe do to bring some of those to light, because we do see them in the hospital gouging bills and others that we've looked at with some of the work that we've done around in that specific space.
Bill, it's important to note that, again, one thing that the insurers and the pharmacy management companies and hospitals fall back on is that look at out-of-pocket costs for patients, specifically for drug. It's been on average going down. But the two things they leave out is, number one, premiums have been going up. So yes, maybe the average out-of-pocket cost has been going down, but the premiums are going up. But more importantly, what they don't talk about is that it's a small number of percentage of patients that really get hurt. And it's just, that's the problem, is that the average person probably is not going to get hurt to 340B or rebate contracting and things, incentives such as that. It's a small percentage of patients, but they take the brunt of that. And that's the problem, that it's sort of like you're creating a very uneven, unequitable environment for patients.
Yeah, this is a hobby horse of mine, because I know 15 years ago, drug prices were rising significantly and drug costs. And this was a problem for the healthcare system, but that's largely changed. It's average drug prices have declined for 4 straight years. I'm not saying it's easy for every patient to get drugs, but the mix of drugs that are coming out onto the market are more specialty, rare disease and orphan drugs. Those tend to be more expensive. And if you're in a high coinsurance or high deductible plan, and you get prescribed one of these drugs that's $80,000 and you have a 25% coinsurance charge, you have an issue. And that is a small amount of patients, but it's a large number of prescriptions. And I believe that's what's driving the resurgence of the drug pricing issue from a political perspective. But the policymakers tend to blame it on drug prices, which I think isn't the right data point at this point. But that's a side issue.
Well, no, not really. I mean, that's why we've been really trying to reshape the dialogue around a lot of this, that there's not a drug pricing crisis in this country. There's a benefit design crisis in this country.
And a transparency crisis.
And a transparency crisis to go with it, for sure.
Okay, well, this has been very, very valuable. We're going to give people a minute of their time back. We're a few minutes from the closing things out, but I think I'm going to closing things out. We've answered every question, and thank you to the both of you. This was very interesting and discussion.
Absolutely, happy to, and support your state bills for transparency on 340B. That's what I would say. Thank you.
Thank you.
Thank you.